thank you so much. It was a wonderful prior panel, and today I'm delighted to introduce Dr. Ehrenfeld, and we're going to have a nice fireside discussion. Please put your questions as we're talking online, and then we'll also open up to live audience questions. So I'll introduce Dr. Jesse Ehrenfeld, which is a difficult task because he wears many hats.
Just ask the large language model.
Yeah, just exactly. Everybody put it on ChatGPT. It may do a better job than I will. But he is the current president of the American Medical Association. And he's also a senior associate dean and tenured professor of anesthesiology and the director of Advancing a Healthier Wisconsin Endowment at the Medical College of Wisconsin. He's been on the AMA board since 2014. If that's not enough work, he also divides his time among clinical practice, teaching, research, and directing this $560 million statewide philanthropy. He has adjunct appointments at Vanderbilt University, and his research really focuses on understanding how information technology and digital health can impact perioperative outcomes. But fun fact about Dr. Ehrenfeld is that he was actually a resident at MGH with my husband, Sam, and I think he gave a resident talk, and my husband, who doesn't have a lot of opinions about this, said, that guy is going to do great things.
Oh, boy.
So he certainly did, and we're just so thankful for your time, and thank you for being here today. So I'll kick us off by just asking you, given your unique background as a practicing clinician, as an anesthesiologist, you also have training in bioinformatics and lead a lot of research in that area. How has this perspective influenced your current views on AI in healthcare?
Yeah, well, first of all, thanks for having me. Thanks for this wonderful symposium. Can you all hear me with this? Is that okay? Yeah, great. Okay, perfect. I rarely am in a room, we've been here for, what, an hour or so already, hearing this much conversation about AI where I actually agree with almost everything that's been said. As I travel the country, there's so much uncertainty about how do we get this right. And as a practicing clinician, I was in the OR yesterday, I saw 11 patients. There's so much opportunity to get this wrong. There's so much excitement, there's so much enthusiasm, but we're at that peak of the hype curve. And if we don't have certain conditions on the regulatory side, on the liability issue, sort of a shared awareness around how we have ethical principles that can lift up equity as a foundational way to make things better, not worse, there is the potential for this to go horribly off the rails.
And there was a recent AMI poll survey around physicians and how they felt about AI, and I was really surprised to see that it was generally very optimistic.
Yeah.
So I wonder if you can just give us a couple of summary points of how do our colleagues feel about the role of AI in our healthcare systems?
So 20% of practicing physicians in the US are using AI today, right? So that's a fifth of the workforce. It's the unsexy back-end office stuff. It's supply chain management. It's scheduling, it's fighting for prior authorization approvals with all the third-party payers. Those systems are here, they're being embraced, and they're certainly useful in some degree. 41% of US physicians in the latest AMA Digital Health Survey work are equally excited as they are terrified about AI. And I think what drives that is the experience that we've had with technology. You look at the EHR. Now, I was in the OR yesterday, and I didn't have a lot of pajama time. I was at O'Hare last night finishing some notes in the record. But things have definitely gotten better, but it was a long road. And certainly the number one dissatisfier for physicians for many, many years running was the electronic health record and those usability challenges, a lot of promise of technologies that were going to make our lives better, make things more efficient, give us more capacity, didn't really pan out. And so while there's this excitement, like we all know we're in an AI era, like who's not using these large language models to do various mundane tasks, like writing the opening paragraph for a bio that I need to send to a conference organizer to be on stage, right? Okay, fine. But we want these things to work. So I actually had this very fun experience yesterday. So I walked into my little pre-op holding area to see a patient, and the surgery resident is just finishing her consent. And I knew, because I'm only in the OR occasionally, that we had made some change to electronic consents, right? So get rid of the paper, we have the EHRs, sign digitally. That's fine, all rolled out. They took the paper away, but they forgot to put those little signature pads in the pre-op areas. So I'm watching this resident take an 81-year-old patient and try to sit her up on the stretcher, lean her over to use the computer, like those little mobile computer on wheel things. Horrible. Why would we do that, right? It's just another very simple, obvious example of the place where the technology, the deployment actually didn't really match the workflow and just causes frustration. Like that should be a really obvious, easy thing to do. We can't let that happen over and over, obviously, with these AI deployments.
Yeah, and just to follow that, the EHR adoption in our healthcare system is something that obviously has had a lot of challenges. I was, a medical resident not too long ago in Boston, and we used to have paper charts. And even us as residents were like, oh no, when we get an EHR, we're not going to physically look at the vital sign and we had this DOS operating system at the Brigham. We're just so fast at it. So but of course we adopted, and of course, we had to, but there are challenges, and people and physicians in general seem to be more resistant to change than other stakeholders. So what are your thoughts on the lessons that we've learned from EHR adoptions that all our health systems have, and how we can apply that to AI?
Yeah, I mean, I think that the fundamental mistake was we didn't have the clinician voice present throughout the design, the development, deployment cycle, right? And I see this with companies and entrepreneurs where, yes, there's a physician who might be involved, but it's an afterthought. They're not really driving the development of the solution. That's a problem. We can't let that continue to happen. And certainly, when I think about the journey that we've been on with the EHRs, there's a lot that we need to not repeat the same sort of mistakes.
In addition to the physician voice, I just wonder how you feel about having the patient's voice when we think about AI.
Well, certainly a lot of conversation about what patients are doing. Those statistics about how often millions and millions of people are going to Google to ask health questions. Has to drive some of the conversations. What does it mean for unregulated, at least by the FDA or the federal government, AI health consumer-facing products? The CTA, Consumer Technology Association, is deep in these conversations about how do we make sure that these products actually work, right? When there isn't necessarily a regulatory framework or something that has to be approved for a device to come into the marketplace. As a physician, what do I tell my mom when she goes to an online, tool that takes a picture of her skin lesion and tells her something about it, right? Like, how do I know if that works? How should she accept the result that she gets from an app? I don't know, but obviously we're going to get all these kinds of questions, and as physicians, we're going to need to have some information to help answer them to guide our patients through their health journey.
And it seems like from the physician lens that reducing administrative burden and doing these tasks that we know are remote and can take time, that's a really useful set of skills for AI. In your data, have you seen any other useful tools that AI can help? Yeah,
no, I mean, I think that the low-hanging fruit is getting rid of the busy work, right? The stuff there's a lot. I think there's like 34 sort of digital scribe AI companies out there now, I will tell you, I know of a physician who got one of these tools. Some work I think really well, others have some challenges, and she started crying. Because for the first time in 6 months, she got home for dinner to be with her kids because she didn't have to sit there and finish her notes. So I think there's a lot of promise in sort of detethering us from our computers. For the average ambulatory physician, if they're scheduled for 8 hours of clinic time, they spend 5 hours on the EHR. Like, that is not a satisfier. That sucks the joy out of the practice of medicine, and there's so much opportunity. And yet, I had this very strange experience the other day. I'm going to see a patient, and I think I'm a pretty sophisticated EHR user. I look at the chart, I think I know what's going on. I see my patient, talk about anesthesia, do all the stuff. I'm like exiting the room, and she goes, "Oh, doc, one more thing," and you all know what that means, right? Oh my God. Okay, and she goes, "I just don't want what happened the last time to happen this time." And I said, "Oh, well, what happened the last time?" She goes, "Well, they told me that I had a cardiac arrest in the recovery room." Oh, no. I said, "Yeah, I don't want that to happen either. It's not good for you. It's not good for me. It's a lot of paperwork." So I looked back at the chart, and I had missed that buried in a nursing note in the PACU was this note about a real event. It didn't show up anywhere else, right? Like, I wish I had a tool that flag those things that, like, I ought to make sure that nobody misses as they're going to interact with a patient. That doesn't exist. That's certainly a use case that I think people are starting to think through. That's obviously specialty driven.
Yeah, as a cardiologist, that is very stressful to hear that perioperatively. But so just moving on to the regulatory piece of all of this, yeah. As an AMA president, a lot of your discussions are on advocacy and discussions with Congress. What AI regulatory things would you like to see Congress pass as it relates to our healthcare system? Yeah, so this is a place where I could not agree more with the opening comments that executive orders, great, welcome, thank you, but we need real regulation. And we need to make sure that we have a regulatory framework that supports the innovation and doesn't kill the market. And unfortunately, two things have happened in the last month that are problematic that may require some congressional intervention. One is
the implementation of rulemaking around Section 1557 of the Affordable Care Act, which is the non-discrimination piece, really, really important piece of the Affordable Care Act. Rulemaking around that out of OCR HHS, unfortunately, created this scenario where now under federal rule, if you use an algorithm and a patient is discriminated against because of that algorithm and harm is caused, you solely, the clinician, are liable. Now, should it be solely the clinician? Should it be the developer? We think it should be the person that's best positioned to mitigate the harm. And that may be the health system that did the implementation. It may be the developer who created that foundational model that was biased with the underlying data that I have no idea as a physician. But right now, there's that unfortunate rule that just was dropped in April that is final. The Federation of State Medical Boards, they also recently released a set of principles that we have a little bit of an issue with, which again creates a new duty for physicians and says that the physician ought to be solely liable if there is harm caused to a patient with the use of these tools. Again, that's a little bit of a departure from how we think about shared liability in other contexts around the delivery system. And so as these things sort of work their way through, obviously what will be a lot of litigation with challenges, and we're already seeing cases where patients are bringing lawsuits against systems, physicians, and practices because they think AI ought to have been used in the care delivery process and wasn't. At least one of these cases that I'm aware of, actually, the technology doesn't really exist. And in fact, I think that's probably the case with most of these things, and I appreciate Dr. Mello's comments earlier about that, sort of how do we evolve the standard of care. But this question about liability is a really foundational one. There are four drivers of any adoption of a digital health tool, whether it's AI enabled or not, that we see over and over and over again in the AMA's research on this. One is, does the thing work? And that should be a simple question, but it's not, right? So what's the level of evidence that we need to bring an algorithm or a new AI tool into the marketplace? I agree with the FDA that the system that was set up in the 60s and 70s with our product reviewers and that has worked well for drugs and biologics does not work for AI-enabled algorithms, particularly if you think about managing all the software changes as things evolved. But what are we left with, right? Is it just a permissive, you follow the best good machine learning practices approach and you can bring anything you want into the marketplace, where we are totally reliant on post-market surveillance to know if things are working or not? We're not set up as a nation to deal with that. So that causes me a little bit of anxiety. In fact, that is the one thing that keeps me up at night, is thinking about a framework where hundreds of algorithms are deployed at scale and we don't really know if they work or not. The second is this liability question that physicians want to know. When something goes wrong, who is on the hook, right? If I use it as directed, as intended, and something is wrong with the underlying model, why is that really my problem? Right now, again, there are these proposals that say it is. The third is, payment issues and how do I recoup the recovery costs? And it's interesting if, you look at all the firms over on Sand Hill Road, they've pulled back a lot of investments in companies that are trying to sell to hospitals because the margins are gone, right? So what's the ecosystem around the adoption of these tools and payment and those sorts of things and economic incentives? And then finally, this is actually work in my practice. And I will admit, I made this mistake when I was in Boston. Early in my days of doing decision support development, I built some software and an algorithm at our adult hospital. And then I know this. I know this. I went to med school. I know that children are not small adults. And yet we just turned this thing on at our children's hospital. And it failed miserably because the workflows were totally different, right? And so we see that mistake happening over and over and over again. And physicians want to know that, yes, it works in some setting, but does it work in my practice with my patients the way that I deliver care?
Yeah, that's a great point. And we heard that in the last panel around understanding the local context, that one solution you can't just plug it in. You have to kind of test it. So I think we'll move on now to some audience questions, so we can take some live questions. But while people get set up, I just wanted to bring this up because it came up online. So you have spoken very passionately about health equity and making sure that patient voices are heard, particularly the LGBTQ plus population. What are your thoughts about the opportunities for this population within the AI revolution? Is there something that you're hopeful for and something you're worried about?
Yeah, well, we continue to see circumstances where patients are left out of the development process. And you look at all the conversation around pulse oximetry and the calibration challenges, and the shocking thing about the fact that pulse oximeters overestimate oxygen in people with dark skin tones is not the underlying problem. The problem is that we've known about this problem for 30 years, and it's never been urgent enough to deal with until now. Finally, the FDA is trying to decide about calibration studies and labeling and what we ought to be telling people about this technology. If we are not very explicit, very intentional in making sure that innovations are designed for underserved communities, we will make sure that they will be left out.
Questions from the audience?
A sea of hands.
A lot of hands, yeah.
Hi,
And please
thank you.
introduce yourself.
Hi, I'm Roxana Donistru. I am an AI researcher, a dermatologist, and I also sit on the American Academy of Dermatology's AI Standards Working Group.
Great.
And my question is, so let's pretend that we might be held liable for how we use these models. And from one of our surveys, we actually found that 65% of dermatologists were using open large language models in their clinical care, some even daily or weekly. And my question is, a lot of physicians do not understand how these models work, where the errors might be, where the biases might be, in order to make a good decision about when to use the model or how to use the model. And I've been involved in trying to do this education, but from the standpoint of the AMA, how do we build sort of an educational framework to bring our medical students, residents, and physicians up to speed and to understand the limitations and cut through the hype?
Yeah, great question. And there's a lot of work that we obviously need to do. It's funny, 10 years ago, 50% of medical students never touched the EHR, right? How could you imagine graduating from medical school without being able to touch the EHR because of, the framework that we had around access and provisioning and not letting people enter notes. So there's a lot that obviously we need to do on the education side across the UME, GME, and continuing professional development continuum. But a couple of foundational questions about, what should we know about these tools as we bring them into practice, right? What should that standard of transparency be? And I will give you that explainability is a tough nut to crack, and obviously there are people that they're experts in the room. They're working on trying to figure out how we can make these models more understandable in terms of what's driving a decision, and that's all great. And we should certainly follow kind of best practice in that space. Explainability is different than transparency, and we all ought to demand transparency. I should never walk into an operating room, turn on a ventilator, and not know that there's an AI algorithm that's trying to optimize inflation pressures. Like, that should be unacceptable. And yet, we have seen this problem happen in other industries. You look at the 737 MAX problem, the original problem with the two crashed airliners that tragically killed hundreds of people. It was an AI safety system that Boeing created because of the increased lift on the larger engines, the placement on the wings caused the nose to go up, so they created this AI safety system that just gently pushes the nose back down. They didn't tell the pilots. There was nothing in the operations manuals. There was no training, there was no transparency, and obviously we know the result of that, right? Tragically, hundreds of lives were lost. We can never allow AI to come into our healthcare system without having transparency around its existence. It's the only way to have the human in the loop as the final backstop around these tools and technologies.
Hi, I'm Danny Fortson from the Times of London. I had a question around moving AI from this kind of the hype to the clinical setting, and how important it is to have explainability in terms of regulation and getting these things approved, and in interacting with patients. Because if a lot of these models are effectively black boxes, and to your point around liability, when things go wrong, how does that all work, and where are we in that process?
Yeah, I think explainability is probably less of a prerequisite for adoption and deployment at scale, because again, I think there are just going to be foundational challenges with how these models work with millions and millions of parameters. Who knows what the thing is doing? But that doesn't get us out of a requirement to know that the thing actually works, right? And so what's the level of real-world evidence that we ought to have to make sure that AI is valid and is working and is not causing harm? And that is an open question. And there are a lot of groups. I have a spreadsheet on my computer that I was trying to track all of the groups and the coalitions, and when I got to 17, I just gave up because there's so many that are trying to figure this out. And so frankly, I am very delighted to be here in beautiful Palo Alto, where the weather's always nice. But I really appreciate this symposium and this collection of people who are trying to understand how do we move this conversation forward, hopefully in a way that is maybe a little bit less self-interested.
Other questions from the audience? Yeah.
Hi, yes. Dorianne from the National Women's Law Center and deeply steeped in 1557. So have a quick question about that.
Yeah.
You've talked several times about the responsibility that providers actually have to be more engaged in understanding of the AI that they are utilizing. And earlier we heard from another panelist who talked about the diffuse nature of AI and that there really is a need for governance and accountability at every single step. And I'm coming from the perspective of being in spaces like this and not really seeing many Black women, not really seeing many Black men, not seeing populations that are disproportionately impacted by these biased technologies that are then compounded by sometimes biased providers, whether that be implicit or explicit bias. And so I'd like to hear from you, if we're not talking about individual accountability, if we're not talking about individual liability, how do we hold providers accountable, not just for their individual bias, but also for the bias that is sometimes built in and compounded 3 times over in the AI that they are utilizing?
Yeah. There's a lot to unpack there, and at the end of the day, there's a lot of bias in the system today, right? We know that. I see that, right? That is unacceptable, and we need to call it for what it is, which is something that we need to correct. The question is, how do we use these tools and technologies to make sure that the problem is improved and not worsened? And unfortunately, we're on a course where, without intentionality, without us being explicit about what we demand of these systems, where we will exacerbate these biases. And the AMA is involved in a lot of these sort of tech equity coalitions to try to make sure that, like the info health work that we've done, to try to make sure that we're trying to push this forward in a way that makes sense, the equity problems are addressed. But at the end of the day, I think we have to make sure that patients' voices are lifted up, particularly from marginalized communities that are often invisible.
So there's some questions coming in online. So patients may have concerns about the reliability of AI tools. How can we communicate as healthcare providers and practitioners effectively about the benefits and limitations of AI? It's a tough one.
Yeah, well, I think we have to be honest, right? The first time I had to tell a patient I didn't know something and I needed to look something up, early in training, was a very humbling moment. Right, and we all ought to acknowledge that there's some really, really powerful things about these tools that can help us as clinicians, that can augment our capabilities. And by the way, for 5 years, I feel like I've been beating my head against a wall by using the AMA's preferred language around augmented intelligence, not artificial intelligence. And finally this year, and I was just so delighted when in the kickoff welcoming, this concept of augmented intelligence was highlighted. But that means that, again, we are still there. And I think, being just clear and open and honest about, what we know and what we're using these tools for is one way to try to make things better for patients.
Ala Youssef, Stanford Amy postdoctoral research fellow. I guess one question I do have is in education always lags behind how technology develop. From your perspective, what is the sort of new skills or tools any medical students graduating from medical school should have in the next 5-10 years in order to be able to use AI responsibly in their clinical care? So what are the sorts of skills, rather than curriculum or content, what are the sort of skills we need to see in the new physicians so that physician using AI will use that responsibly?
Yeah, so the good news is we don't have to start from scratch. There's been deep work around creating entrustable protectional activities, EPAs, and a competency for frameworks for informatics that the AMA was deeply involved in trying to sort of lift up. There's even a textbook chapter or two that I may have written on that subject. But the AI piece isn't fully fleshed out because it's so new. So there's certainly folks around the country that are trying to think about, as these tools come into practice and evolve, how do we need to go back and adjust that foundational work sort of at the UME level? And then what does that mean, of course, across GME and then for physicians in practice?
Great. More questions?
We're good. Hi. Thanks so much. I'm Matt Eisenberg. I work in medical informatics at Stanford Healthcare and regulatory informatics. My question is about the legislation that's coming. It's being written now in D.C. It's being written in Sacramento. We're following lots of new legislation. And frankly, when I see the drafts, I'm kind of appalled as to what's being put into that regulation. So my question is, what can the AMA do? What can our state medical society and associations do? What can we do to educate our legislators about how to write this legislation in a way that actually is both responsible, equitable, but also rational? Because some of it is just not.
Wow, how do we get our legislators to be rational? There's probably a large language model for that, and it's just do the opposite of the thing that Jesse would tell you to do. No, your point is right, and what I worry about is in our federated approach to government, right? You have things that you can do in 5 states, but you can't do in 10 others, and what a mess, right? From a development standpoint. We're sort of there to some degree on the global landscape. I was in Germany last week with my counterparts over there. 2 weeks ago, I was in Seoul, Korea with about 75 of my counterparts from across the globe. There are nations in the world where you cannot use any of these AI tools because of privacy regulations that have stalled that innovation. We don't want that to happen, right? We don't want our patients to not benefit from these amazing innovations that we all know can make the practice better, that can augment our capabilities. But how do we do it in a unified, harmonized way that balances that need for privacy, security, protection of patients from harm while allowing the innovation to still happen? I don't know what the answer is in terms of like some of the bad ideas that are out there. Certainly, the AMA, we have a we've put out our foundational AI policy in 2018. It's not new. We did a big refresh this past year. It's on our website. It's long. There are a lot of components in it, and there are a set of companion model bills that we have shopped around to state policymakers, as well as obviously we're trying to navigate what's happening on the Hill in Congress to get this right. But there's a real risk, right, that we end up with all sorts of funniness around what you can and can't do depending on the jurisdiction that would be potentially a limiting factor for innovation.
We have time for one more question.
Good morning, Jesse. My name is Maya Yadam. I'm one of the emergency physicians at Stanford and also run an AI lab that works closely with our clinical operations team. And must say that I also, our team has developed an algorithm we've worked on for many years that we found it was racist. And in that, it was exacerbating disparities amongst our patient population, even though it was improving performance. And so we spent the last 2 years debugging this algorithm and finally have figured out after much work that it's a feature of the algorithm. We had to add different features to the algorithm, not to change the algorithm for it to perform the way it needed to. The only way we found this out was by integrating it into the hospital system and testing it silently. So in many ways, some of the work that we're doing is integrated with biodesign here on our campus. That really is about innovation, and many of the tech companies who are developing similar tools don't have the advantage of integrating into hospitals. And then when we do integrate into the clinical care setting, it's usually using the clinical research framework, which is really slow. What do you think we should be doing to really bridge that gap between time and rigor?
So rigor is the right word. And I will tell you, when I was at Vanderbilt and we went from homegrown EHR that everybody loved to a commercial product and we had to look at all the rules, right? It was the first time, I think, ever that the thousands of clinical rules were cataloged. And we realized that there were just hundreds of things that didn't make sense, that actually were not working. And so I see all the time lots of development around a rule set or some decision support or AI-backed things. It gets deployed, turned on, and then forgotten. Because there isn't that rigor to continuously evaluate the model, the output, the algorithm to see what's happening, which takes a lot of energy and a lot of time and a lot of money to do. And there are very, very few centers that have that level of rigor and commitment to doing that. But that's actually what we need to make sure that these things work. I mean, there are dozens of glorious examples of horrible failures of the sepsis sniffer gone wrong at large health system X, right? That describe sort of the things that you're saying. So I commend you for what you're doing, but making sure that, again, we don't have innovations that are disconnected from not just the workflow, but the actual experience of our patients to make sure that these things get sorted out is really, really critical.
Thank you.
Thank you so much, Dr. Ehrenfeld. That was really a fantastic discussion around what we've learned from the adoption of EHR, how we're going to apply that to augmented intelligence in our healthcare system. And I'll have to tell my husband he was right. You're pretty amazing and delighted.
Tell my mother, please.
Give her a call. And thank you again. I'd like to welcome the next moderator, Dr. Sammy Collejo, for discussion on public-private partnerships. Thank you so much.
was fun.